Hi everybody, welcome to today, and we would like to thank you for joining us and our webinar about person-centered care and reducing complaints in ART service delivery. My name's Anna McLeod and I am the CEO of the Victorian Assisted Reproductive Treatment Authority, and I'm also joined by a representative from the Health Complaints Commissioner and from AHPRA today, and I'll introduce each of them in due course. But before we get started, I would like to acknowledge the traditional custodians of the various lands on which we gather today. We have people from both Australia, New Zealand, I believe, and I'm not sure, I think there might even be some other international participants. So we do pay our respects to their elders past, present and emerging. The format for today is that there are 3 speakers, myself included, and we're going to aim to each speak for about 15 minutes each. And then we're going to allow around 1/4 of an hour for questions and answers. Now, some of you have already submitted questions for our speakers, and we will try and address some of those as we go through. But at any time, if you have any additional questions throughout the presentation, we would like you to type them into the Q&A function at the bottom of your screen, and we will endeavour to respond to as many as we can before the end of the hour. Now, I would like to start by introducing Rosalind. Now, we do have a late change to one of our speakers, and that is the Victorian Health Complaints Commissioner, Karen Cusack, will not be speaking today. Instead, we have Dr. Rosalind Herder. She is presenting the findings of, and on behalf of the Commissioner's Office. Karen has recently stepped down as the Health Complaints Commissioner, but we do have her interim replacement also joining us today, Elizabeth Langdon. She's been appointed the acting commissioner, and she's got an incredibly impressive CV, so you can check her out on LinkedIn. So I'll pass over now to Rosalind, but I just want to obviously talk to you about her bio. Also very impressive, and she's also more than qualified to speak today on this topic because she actually led the team to complete the Health Complaints Commissioner inquiry into the Victorian assisted reproductive treatment industry back in 2019, and the findings I think were delivered in 2020. So she's actually received a PhD in medical history from the University of Melbourne. He's also followed that up with a postdoctorate Fulbright Fellowship in Medical History and Bioethics at the University of Wisconsin-Madison. She's worked in the public sector for many years, both in the departments of Veteran Affairs and also Premier and Cabinet, and both at federal and state level. She's also published widely in the fields of military medicine, Australian peacekeeping and trauma and post-traumatic stress disorder. So over to you, Rosalind.
Thanks, Anna. Can everyone see me? Well, I just assume you will. So many thanks to Anna and VARTA for hosting this, and welcome to our Acting Commissioner, Elizabeth Langdon, as well. I'd also like to start by respectfully acknowledging the traditional custodians of the lands which we meet today. For me, it's the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past, present and emerging. Next slide. So just a quick reminder of what the Commissioner does. We resolve health complaints as an independent and impartial body between providers and patients. We investigate providers who pose a risk to public health. We investigate breaches of health privacy, and we conduct inquiries such as the ART inquiry. Next. So the ART inquiry, it's all started with the Gorton Review in 2019. Michael Gorton published his review proposing reforms in Victoria's legislative and regulatory environment regarding ART. The review concluded that, quote, Victoria's regulatory framework for ART is no longer fit for purpose, and the system for delivering ART does not adequately put people at the centre of fertility care. So following on from that, the then Minister of Health asked the Commissioner to complement the Gorton Review by looking more directly at the patient experience. So what ART services are currently available and how are they being used by patients? This also followed a period of very negative media towards the ART industry. An analysis of 2,000 media stories on IVF showed that 73% of the negative stories came from Victoria. So we really wanted to get to the bottom of this. Our report was published early this year and is publicly available. I urge you all to read it. My dad said it was great. Most of our findings largely support the relevant reforms of the Gorton Review and also align with VARTA's Guide to Patient-Centered Care that Anna will be speaking about later. Next. So our data came from 121 submissions through statements and semi-structured surveys, both to the public and providers and clinic staff. Statements were made. Also, we had held consultation forums with the public and providers in Melbourne and Ballarat. We also analysed the ART-related complaints to the Commissioner from 2017 to 2019 to provide a bit more context around the inquiry. And we sort of anchored all of that in national and international academic literature on ART. Next. So the Commissioner made 17 recommendations, including relating to communication, complaints handling, adverse events, counselling services, and the use of adjuvant or add-on treatments. All of our recommendations focused on ways to help providers improve the patient experience. So today I'm just going to focus on the first two, communication and complaints handling, which made up almost half of our recommendations. But first, I'll quickly do a run through very quickly of the main findings of our inquiry. Again, the entire report captures more of the whole picture and some very interesting personal perspectives from patients and providers. Next. So the majority of our submissions came from consumers, including partners. Statistically, our average consumer submitter was female, chose to be anonymous, underwent ART in the past decade, and were treated in Melbourne, including rural and regional travellers to Melbourne, and overall had a negative experience. We were very lucky to have great engagement from ART providers and clinic staff to tell us their perspectives, their frustrations, and their ideas for improving the patient experience, which really helped our understanding of the industry from their point of view. Slide, please. Next. So only just over half found or rated their experience as negative in receiving ART. And 41% said their experience was both positive and negative, and 8% said it was positive. So obviously there's some caveats to our data. Our inquiry was voluntary, so there's potentially self-reporting bias, and there's also probably negativity bias where people are more likely to recall negative experiences. Complaints were biased to whether there was a positive pregnancy result, but not always. So it's important to highlight that a lot of consumers went to lengths to praise their provider's care, regardless of their treatment outcomes. We had to interpret some of the submissions when detail was missing. If submitters consented, we would often contact them afterwards and talk to them about a bit more about their experience, get a bit more detail, fill in the blanks, and get a better insight of their experience to add to their submission. There's also differing levels of medical literacy. So some consumers didn't know the difference between an adverse event, a side effect, and a medical error. And we make no claims. Can you go back? We don't make any claims that this is a comprehensive study. It's absolutely just indicative, but it's somewhere to build from. We were very aware throughout this process and from speaking to providers all the way through that we know this is a unique medical field for extremely high expectations for patients and the anxiety through every stage of treatment. As one provider told us, ART is a complex and emotional experience for our patients and their support networks with no guarantee of success despite the financial outlay required. The emotive nature of ART treatment can lead to increased levels of frustration as the expectation of what treatment can achieve may not meet the reality. With the development of the internet and reliance on Dr. Google and the introduction of social media and blogs, patients are increasingly informed. Next. So what constituted a negative experience for consumers? So the blue line is the primary complaint and the green line is the secondary complaint where often submissions had multiple complaints. So you can see communication was the top problem. One of the most common threads in every complaint we receive at the Commissioner's office is about communication. So it's natural that this would be reflected here as well. With costs, interestingly, consumers complain more about how costs were communicated rather than the costs themselves. Slide. So what were some of the main communication issues? Some common themes were lack of aftercare, especially after a failed cycle or an emergency, difficulty getting information about treatments and side effects, or having to chase test results, understanding the differences between side effects and adverse events, especially ovarian hyperstimulation syndrome, opaque success rates between clinics, different treatments offered by different clinics and often between clinicians in the same clinic, and not understanding why one clinician would offer one procedure and another wouldn't. Medical errors and poor explanations of things like embryos being accidentally thawed or destroyed, and procedures not being performed by their chosen specialist. Conversely, we saw examples where consumers felt their ART experience was very positive, slide, primarily because of good communication from their provider. So returning calls, feeling that they weren't a number, feeling that they were responded to. Obviously, for ART providers, that's high management, but that's what we received in the inquiry, where they pointed to good communication. Slide. So in terms of complaints handling, in general, consumers showed very poor knowledge of how to make complaints. Many didn't know they could make complaints to the HCC or APRA. 69% reported they were never informed about complaints procedures by their provider. But an interesting barrier that we found was that even if patients wanted to complain and knew how to, several chose not to for fear that it would affect their treatment. This is very common in the submissions, and I think largely why most of the submitters who were consumers were anonymous. So typically, this is one statement we got. One patient wrote, "Please ensure I remain anonymous in this review, especially as I'm receiving ongoing treatment with my ART provider. It is very important that I retain a comfortable and open relationship with my doctor and the nurses. For these reasons, I haven't complained directly to the ART provider or my doctor about any of the issues raised in this submission." So we found that an interesting point. Slide. Looking at counselling, the majority of consumers stated they found it largely unhelpful. Most of the problems were around timing. Patients wanted counselling after cycles, not before them. They felt a conflict of interest where counsellors were attached to provider clinics. So they felt they couldn't be honest because they were also afraid that would affect their treatment. And some found that the information was too legally based rather than emotionally supportive. But despite the criticisms of the counselling, that did not equate to consumers wanting to remove it. So what we heard consistently was that most consumers wanted more counselling and better support throughout their treatment journey. Next. Looking at adverse events, these are just the top 4 that we received information about, that not all of the adverse events. So moderate to severe ovarian hyperstimulation syndrome was the most common, followed by damaged or removal of ovary, drug reaction, and pregnancy complications. So a quarter of all our consumers reported an adverse event. And it's important to note that the instances of OHSS that were reported largely ended in hospitalisation. So in 2018 to 19, VARTA received 58 reports from Victorian ART providers of clinical adverse events, and 27 of those related to moderate to severe OHSS. So we got 16 instances across 93 consumers. So as the Gorton review also noted, it seems that performance across clinics can be highly varied in reporting adverse events, and that OHSS in particular seems to be underreported. And I understand VARTA is currently looking at the reporting of OHSS and its parameters. Again, in our inquiry, this was largely down to communication. Many consumers who experienced OHSS were not aware that the hormone stimulation process could cause it. and some reported not understanding what was happening to them as symptoms developed and having to Google them to find out what was wrong with them. Slide. Some other perspectives we received through submissions was the need for more inclusive practices and cultural safety for LGBTQIA patients, Aboriginal patients, solo patients, and low-income patients, better access to ART services in rural and regional areas, and that men often felt left out of the process in the journey. Even though infertility is a big issue, a lot of men who made submissions said that they wanted targeted support for partners. One submitter noted, "We were told about the IVF procedure and felt well informed about the medical aspects when beginning treatment. We were not told, however, about the social, emotional aspects for either the birthing partner or the non-birthing partner." Slide. So that's a very quick look at the inquiry. What now? So I've been given the task of implementing the inquiry's recommendations in partnership with providers and regulatory authorities. And for all of you who are in the ART sector, this is where we can help you. Two of the main areas of expertise and training we provide at the Commissioner's Office are improving communication between providers and patients and helping providers with ways to reduce complaints, better adhere to complaints handling standards, so that you can resolve complaints yourselves, patients are satisfied, and that those complaints never get to our office. So this is really our bread and butter, and this is where the focus will be over the next few months as we implement our strategy following the publication of the inquiry. Many of you will soon be hearing from Acting Commissioner Langton and me as we work to progress these recommendations. Again, I encourage you to read the report, and please contact me anytime to find out more about the inquiry or if you have any questions. Thank you all so much for your time.
Fantastic. Thank you so much, Rosalind. That was great. And also, I believe Rosalind and Elizabeth have both offered, if you would like a full session, a complete hour on this topic. I do understand that that is an option that might be on offer if people were interested. But now I'm going to continue today's presentation by providing information on VARTA's guidance, on person-centered care. So thank you. Next slide. So I have actually presented on this topic only once previously, so I do apologise actually for those who attended the FNA conference earlier this year. But for you, I'm glad if you did turn up today, it will be a bit of a refresher for you. But how did this come about? For the same reasons that Rosalind has already alluded to. So the Gordon Review in 2019 obviously concluded that there was, clear and comprehensive, a need for clear and comprehensive information and good communication to allow people to make appropriate choices for themselves and their families. And so that meant that the Minister for Health at the time, Jenny Mikakos, also approached VARTA as well as the Health Complaints Commissioner and did request that we produce a guidance on ART clinics and person-centered care. Well, what is person-centered care? It is, of course, being responsive and respectful to the preferences and needs and also the values of patients as well as those supporting the patients. And also there's several widely accepted dimensions of care, and we're going to actually cover several of those briefly today. So what are the benefits? Next. Wow, it is, of course, in practicing and embracing person-centered care, at a minimum, there's a threefold benefit. It's actually potential benefits for patients, staff, and the clinics themselves. What we see when you really provide a holistic person-centered care model, we see increased satisfaction and emotional well-being of your clients. We see enhanced ability for their own self-care. We see that people bring a better understanding to compliance to the treatment protocols. Therefore, there's less adverse events or, misunderstandings, and therefore there's a higher chance that people actually continue treatment and until a viable pregnancy is achieved. For staff, we have less complaints, we have less stress, of course, with less unhappy clients, and increased job satisfaction and more pride and increased engagement and retention, particularly important in COVID context of the Great Resignation. So with people rethinking how they want to spend their time in their profession. It's also great for clinics because more patients persist with treatment, provided treatment's warranted, of course, and more positive patient reviews and recommendations and fewer negative reports. Next slide. So let's go through some of the elements. Obviously, providing thorough information and delivering it in multiple ways is incredibly important. Patients always value that face-to-face consultation. And I appreciate that people will often have to convert to telemedicine and telehealth in the world of COVID, but they need adequate time for questions and written information to understand the complexities of treatment. They get smashed with so much information, medication information, treatment options, financial information. So how do you deliver that information, and do you deliver it in ways that they understand? And also, do you break it up into bite-sized parcels of information over different points in time so that they just don't get come in and get overwhelmed all at once? Do you use diagrams and graphs and present information in multiple ways? I'm a visual person. I love seeing things visually. So how do you present it, particularly with some people, English is their second language, or just being obviously sensitive to diversity and inclusion and what language we use. So, what available information is there on potential risks and benefits? What about that chance of success considering a person or a couple's personal circumstances? I think generally in my experience, people are very good at the objective presentation of information, but they've also got to tailor that subjective viewpoint of what is specific to the person that you're talking to, whether it's a solo person or a partnership and a couple. So what are the chances that multiples, what it's important to convey, of course, that multiple cycles might need to be needed for a reasonable chance of success. And, we're really doing a lot of work, VARTA, in promoting about explaining to consumers about the importance of the cumulative live birth rate that you need to have for many people, multiple cycles before you're likely to succeed in IVF. So how you give comprehensive information about out-of-pocket costs. And, we particularly have focused this year on making sure clinics are really providing evidence base for novel treatments or add-ons if they're offered. What are the systems whereby you can access your treatment plans, your appointments, your medication test results in a timely and streamlined way? So also you need to know how to make and provide feedback for clients and how they can make a complaint. And, contrary to the view that, complaints are difficult, I see every complaint as an opportunity to improve. And so embracing that culture of making it easy for people to provide constructive feedback. Next slide. So again, I'm a visual person, and I just think of how poorly, I think, in my view, AstraZeneca was promoted in the media about the dangers of AstraZeneca, when in context, there were some significant risks, but they were really quite small in terms of percentage-wise. It was more dangerous to get in your car, or more likely you could get a DVT from flying overseas. So I think that's really important. Next slide. How you present information is it's allowing people to make informed decisions, not about just promoting, and really marketing why they should have a particular treatment option. So do we say 95% fat-free, or do we say it contains 5% fat? The way we say something might actually influence a patient or a consumer. So with some very interesting data, is it 99% safe, or is it 1% risk? Next slide. You can see that in this really interesting study, which is quite an old study, it's back from 2000, but in actual fact, when you say it's 1% risk, more people were likely to not go ahead with that treatment compared to whether you said it was 99% safe. It's really quite interesting. What are you saying about ICSI? Really, the evidence shows that ICSI is definitely important in male factor infertility scenarios, but do you really need ICSI outside of those if there is no male factor infertility? Would I be better off having 3 runs of IVF or 1 round of IVF with a myriad of add-ons? You know, what will actually increase my chance of a live birth? These are all the things that consumers really want to know. Next slide. So we need to think about the systems that we deliver person-centered care in and how we train staff. And, you know, I'm going to go quite quickly because we're limited in our time, but really this is about leaders prioritising and promoting person-centered care. Make it key performance indicators for your staff, but engage them and encourage them about every person is important in communicating. If you had, for example, a scenario where you know, the nurse rings up the patient and says you had 2 embryos, you know, 2 embryos fertilized, and then they ring the embryo, and the embryologist rings up the patient 1 hour later and says only 1 embryo fertilized, you know, 1 egg fertilized to create an embryo. You know, the person's confused. So how do you holistically work together, you know, to communicate to clients, to give consistent information so that the medical practitioner specialist, the nurse, the phlebotomist, the embryologists are all singing from the same song sheet and giving consistent information and supportive information, and not conflicting information. Have adequate staffing, you know, educate and invest in your staff to train them to talk about at the centre of all things should be this person-centered care, and delivering that. And how do we learn from our successes, and how do we learn from our failures, and encouraging that you know, quality loop and constructive feedback. Next slide. There's this fantastic article. I thank Karen Hummenberg for bringing it to my attention. It's about teaming. I get it that everybody says, oh, it is, what's the new buzzword? You know, I know about teamwork, and I do understand teamwork. The foundation of teaming is based on teamwork, but in a nutshell, teaming really refers to this dynamic process. It involves the coordination and collaboration of each team member. And I get that you might think that is, you know, what teamwork is as well, but the difference in teaming, which takes it one step further than teamwork, is that it's really about applying teamwork to a dynamic, evolving, ever evolving and constantly evolving environment where you need to take a much more flexible and agile approach to teamwork. So think of emergency departments, think of ART clinics in the midst of, you know, COVID and the context that we had to be active and adaptable and flexible in our processes, and that staff can work together to generate new ideas and solve problems and serve patient needs. It needs to be non-hierarchical, and it needs to provide staff psychologically safe places for everyone to speak up. Next slide. So with continuity of care, another really important issue that we've found, that patients like continuity of care. They like building relationships with staff who they know and who understand their individual circumstances. So how can you, wherever possible, minimise, you know, how many people a person interacts with, so that there's, you know, a smaller number. You can create teams, a blue team and a red team. I'm in the red team, so I know that here's my nurses, my doctors, my you know, my embryologists are going to be limited to a smaller number of people. Give them their names and photographs. Do people always wear badges? Because when everybody appears in scrubs, you don't know who is who. So just setting patient expectations, you know, if you do need to converse with multiple people, and who they are and when they'll contact you. So we also think it's really important about giving clear instructions for patients about who they can contact when they need to outside of hours, and you know, making sure that people answer the phone after hours if they're given a phone number that they can ring, that it's actually somebody answers that. Next slide, please. So also, as been raised by Rosalind, about Hyperstim is a significant issue, and we have found that perhaps there's been some underreporting, but in part we take responsibility, VARTA, in the Victorian context, that perhaps we were not so clear about what we wanted clinics to report. So if we're releasing our annual report on Monday, and I know this is the type of thing the media might want to run with, and we'll accept responsibility for not being as clear as we could have been with our definition of what we wanted reported. We do want, and have now, we do believe that we've made it very clear what the definition will be going forward, that it is anything that results in an overnight stay in hospital needs to be reported. And we've done a recent audit and we're so grateful for the clinics who have assisted us, and we've got revised numbers now for the last 3 years, and you can see that now we're up to a much more accurate representation of perhaps what the cases are in Victoria, in the Victorian context, and we are comparing those with all the coding data that VARTA get as the Victorian Agency for Health Information. So it is a lot closer to what it really should be. Next slide. So of course, providing comfortable physical space and environment and protecting patients' privacies is absolutely essential. I've visited many ART clinics this year, and certainly the reception is not necessarily the most private space, and you do have to give. I just had to introduce myself and say who I was here for, but sometimes people do have to provide quite private information in that reception area. So have a think about, can you construct yours so it is more private when speaking to the person at the front desk? Next slide. We also, the world is a changing place. What makes up a family, people choosing to be solo parents by choice, people in same-sex relationships. We really have to be respectful of diversity and inclusion, and we really have to provide spaces that are welcoming. If all your photographs are of the heterosexual normative sort of, male, female, that really puts people off. I mean, we need to be respectful of all sorts of, representatives of ART clinics, consumers who access ART. And we need to know that people who have many failed cycles don't always want to come and see plastered pictures of babies everywhere. So we understand that the outcome that people want to achieve is a live birth, but, obviously providing different photographs and images is important and balanced. So they're really important. So this was a very moving quote that was provided to us. This is, you can read it. Obviously, this person was said it was a significant trauma leading to them having to seek fertility service as a single woman. She said she was not socially infertile. She thought it was a vile, vile term, and she didn't like the use of it. And although she didn't consider herself being treated badly in a medical sense, because she felt like she was lumped into this major patient group and not in accordance with her circumstances, she said she'll never go back for additional rounds. So that person was sort of lost in just, perhaps in the way, language was used in terms of, and not seeking to find out what her preference was. Next slide. We, yes, absolutely need to look at how we provide emotional support for patients. To Rosalind's point, sometimes obviously the counselling is very important, is all front-ended, and actually it has to be some has to be front-ended because of legal reasons, and I accept that, but it's also about, it's all front-ended. Actually, I needed some counselling at the end of treatment, and so therefore, I would appreciate more the clinics offering more of that. I'm going to have to wrap up because I do need to let Anthony have a go. So I'm just going to go next slide. I did want to talk about a sperm donor's experience, but I think if we have time at the end, I will come back to that. But a specific case scenario was shared with us that we're allowed to share without naming anybody. But I'll come back to that later if we have time in Q&A. Next slide. So really, we just want to talk about the implementation and feedback of our person-centered care guidelines. We do have a self-assessment that you can download, and we've also got all the tools and the actual guideline itself, and also a 2-page summary of that on our website. So that's fantastic. I now am going to apologise, I went a little bit over time, but I really would like to now introduce Anthony. Thank you so much, Anthony, for your patience. It is my great privilege to present him. Anthony McEachran is from AHPRA. He actually heads up the territory manager for ACT. What happened is Clarissa Martin, who was the Victorian manager, has just moved jobs. So Anthony was very kind to fill in while they're looking for a replacement for Clarissa. His past positions at AHPRA were National Practitioner of Audit Coordinator and also Director of Registrations. He's passionate about health and wellbeing, and he obviously said he always strives to create a culture of innovation and empowerment within both government and the legislative frameworks in which he works. He holds a bachelor degree, a master's in human rights, and he's currently studying for his master's in human resource management, so very well qualified, and he's also an active member of the AICD.
Thank you very much, Anna, and thank you to Rosalind as well. Those were two really helpful presentations. Hopefully today, one of the things we'll talk about really is just what we do when we receive a notification, but sometimes things that we can do to help avoid it. So thank you for inviting me to talk to you today. I would also like to pay my respects to the traditional custodians of the land that I am on, and that's the Wurundjeri and Burrungwang people of the Kulin Nation. I acknowledge Aboriginal and Torres Strait Islander culture as the oldest continuing culture in the world. Aboriginal and Torres Strait Islander people never ceded sovereignty, and we recognise the ongoing impacts that colonialisation continues to have on the health of Aboriginal and Torres Strait Islander people today. We also acknowledge Aboriginal and Torres Strait Islander peoples for their continuing connection to culture, language and country, along with elders past, present and emerging, and the ancestors that walk with Aboriginal and Torres Strait Islander people every day. Next slide, please. So AHPRA works in conjunction in partnership with 15 health professional boards. We look after professional standards. We also look after registration, notification, compliance, and accreditation. And we do that across Australia. As of July 2021, we had 825,720 health practitioners registered to practice in Australia across all 16 professions, and that includes 26,000 people on our pandemic sub-register. In the last year alone, a total of 41,000 new graduates applied for registration. And what you're seeing here are all the professions in the national scheme. The scheme is internationally unique in that we do have combined nursing and midwifery, the medical board, and also allied health professions, which you won't find as a model in any other country in the world. Next slide, please. So in order to understand what we do, I think it's probably helpful to talk about why we do it. The objectives of the scheme are first and foremost to protect the public. We also want to achieve workforce mobility for Australian health practitioners, requiring that you only register once, and that enables you to practice across the entirety of the country. Whereas previous iterations of registration meant practitioners needed to hold registration in each state or territory. Next slide, please. What we're looking at here is a little bit of a deep dive. Got some data for you on what health practitioners look like across Australia. And we've called out the particular Victorian context. So you'll see that we have 26.2% of all registered practitioners are in Victoria, which makes the Victorian practitioner population second only to New South Wales. It's quite a large workforce. We see a year-on-year increase. Last year's increase was just over 9.7%, so still rising quite significantly. When the scheme started, our initial numbers were 450,000, so quite a significant rise in the 10 years of the national scheme. Next slide, please. We've been really working hard to evolve our approach as the national scheme has matured and grown, and we're committed to providing an improvement in our regulatory effectiveness. One of the pillars in our 5-year scheme is strategy, and that's key for people, including you, to have trust and confidence in the scheme, and for communities to have trust and confidence in the practitioners that we regulate. We do work hard to continually improve what we do across a number of different areas that will help make a difference to our own effectiveness and the experience of those involved in the notifications process. So we're going to cover some of this off today and the role that you might play. Next slide, please. So a notification, there are a lot of myths and misconceptions floating around about notifications. I'm hopefully going to give you some information to help dispel many of those myths. In its simplest form, a notification is a concern raised with us by a person about a practitioner. Notifications are also a source of intelligence. They prompt us to act, to reach out to the person who has reported the problem, and to reach out to the practitioner that they are concerned about. Now, notifications don't automatically mean that there will be a regulatory outcome, such as conditions. We do receive over 10,000 notifications a year, and the vast majority of them come from patients or other members of the public. Most practitioners hear and believe the myth that notifications primarily are made by other health practitioners or employers, and that's actually not the case. Most of the concerns we receive are about interactions that have gone poorly between the practitioner and a patient or a client. There's also no threshold that needs to be met by somebody who wants to make a notification. That means that we do see a significant number of relatively low level or low serious notifications. And we know that practitioners are often very confused by this. Most practitioners tell us that they assumed we only accept a serious case and then are frustrated when we contact them to let them know we have a notification. We've made significant changes to how we handle these high volume, low risk concerns to help improve the way that most practitioners experience their engagement with us and when we need to discuss a concern with them. Next slide, please. So, as I said, we do receive a high level of low risk notifications, but we have to respond to every notification that we received. And this is the way that most notifications are responded to that you're looking at on the screen. The purpose of the whole process of making, receiving, and managing notifications is to make sure that individual practitioners are practicing safely and professionally. We know that most do, and the process is now very different to the process we introduced over 10 years ago. And this process now reflects the national scheme maturing. It also reflects the fact that our notification process is better informed by clinicians and by people who have been through the process before. Next slide, please. Thank you. So when should you notify us? It's a really common question, and there is no single correct answer. The way I see it, there are two opportunities that employers and other practitioners should consider when making a notification. There is some information to consider about how we might respond in each case that's important to know. So those two opportunities, it's really when you think that there might be a risk to the public because the practitioner is behaving badly, performing poorly, or is impaired to the extent that they cannot make safe decisions for their patients or clients. But you are managing that risk with the practitioner, and the practitioner is doing the things that you need them to do. You can tell us about it. You can tell us what you're doing. Tell us if you think that there is a residual risk that you would need to be managed. If you don't think there's anything that we need to manage, but you just need to let us know, that's perfect. We will want to talk to you about the things that are happening so that we can tell the committee who will be asked to assess the notification. But you shouldn't be scared to tell us and why you think we don't need to react. The second time is when you think there is a risk to the public because the practitioner is behaving badly, performing poorly, or is impaired to the extent that they can't make safe decisions, and you don't think the steps that you could take would be sufficient. That's when you should tell us. So what circumstances might you determine that you as an employer or a supervisor or colleague decide that you cannot manage the risk? Next, yep, that's the slide. Let's call a few of those out. Let's talk about health. So if a practitioner is impaired, that means that they cannot make safe judgments, and they're not aware of that, or they're not seeking help for that. This is the hardest time to let us know. These cases can be the hardest to make a notification about because your instinct as a health practitioner is to provide support. But if the support you provide won't fix the issue, then you might need to ask for our help. We don't want to be unsupportive of an unwell practitioner. Our focus is getting them to a place where help for their health is available. The bottom line is, if this person's health means that they are a serious risk to the public, the law mandates a notification. But it doesn't stop you from being able to support the process or support the practitioner through the process. It means there really does need to be an intervention to ensure patients are kept safe from harm. Secondly, sexual misconduct in connection with a patient's carer or relative or peers. Sexual misconduct is not tolerated. Sexual misconduct can range from inappropriate comments or touching to inappropriate relationships or sexual harassment of peers. You must tell us if you form the belief that a practitioner is engaging in sexual misconduct. It isn't something that can be managed by an employer or a colleague. Third is around practicing whilst intoxicated. If you suspect a peer or an employee who is a registered practitioner has practiced while intoxicated, you must tell us. There are things you can do, particularly as an employer, that should accompany the act of making a notification. If you can, check with HR about whether your contract of employment or credentialing arrangements allow this. Take a sample of blood that can be analysed for drugs or alcohol and have the person's breath analysed for the presence of alcohol. Telling us you suspect a person was practicing whilst intoxicated is a good step. Confirming that they were when you provide the notification or advising us that you have a specimen examined gets the gold star. We may be able to determine whether a person has an impairment that requires support to overcome, but it's difficult for us to be able to assess without the evidence that the person was present in a workplace, putting patients at risk of harm because they were intoxicated. And lastly, if a practitioner is departing significantly from acceptable professional standards, and these standards are placing the public at risk of harm, and it's not within your power to address poor performance, then tell us. If we could move to the next slide. So this screen is just really a little bit about the types of risk and reporting thresholds for different groups. There are some differences about what a practitioner who comes to know one of the 4 grounds in their capacity as a treating practitioner. So I won't speak through that slide, I'm conscious of time. So I'll move to the next slide. Most of the low-level concerns that we receive can be dealt with during the assessment of the concern. Usually we'll want to discuss the concern with the practitioner so we can build a balanced picture of the concern and respond to the concern via the committee or the board. We'll switch to the next slide if we can. So this is our risk matrix. This is how we divide and assess risk when managing notifications. The tool helps us identify the key information available from the notifier and the practitioner or any other parties, and it helps us put it in context. So we're making decisions about the entirety of a situation and not necessarily an individual or a singular incident. Let's switch to the next slide. Some notifications, because of what they are about, will immediately be treated as a high priority. These notifications, by their very nature, require us to make comprehensive and independent inquiries in relation to the allegations, because the allegations are about things that we cannot be tolerated from either a legal, ethical, or risk management perspective. Next slide. And for almost all notifications, how you respond when we're assessing the notification can make a significant difference. I mentioned that most low-level concerns can be dealt with during our assessment. We know that most registered practitioners pride themselves on being safe and acting professionally. We accept that most of the time, when things go wrong, practitioners will intuitively take the steps necessary to prevent the same thing happening again. When we see that this has happened, we can bring these strong individual risk controls to the attention of the committee who will make the decision. Often practitioners will alert employers or system regulators to an incident. So being open and disclosing that something has gone wrong and seeking help to make sure that there's an appropriate response to the incident is a perfect example of strong risk controls. When an employer or organization supports a practitioner to implement an appropriate response and remediation, we identify strong organizational risk controls. These can also support a decision from a committee that no action is required. Next slide. I'll leave this slide here, just give you a moment to have a look at it. It's really what we're saying is it's about the many contributing factors to safe professional practice in healthcare. So we see things as being joined up, not existing in isolation. It's about relationships, connections, and partnerships. That's quite significant in how we manage and assess notifications. So on the next slide, prudent practitioners and workplaces manage risk on the front line. They prevent and respond to adverse events, with all of us then contributing to safe and professional practice and protection of the public. Next slide. I'll skip over this slide because I can see that my timing is getting late. So can you prevent a notification? Ultimately, regrettably, at some point, practitioners will have complaints made about them in their career. Even the best practitioner might have an off day. We don't seek to intervene in relation to safe professional practitioners, but if a notification is received, we are obliged to assess it. Remember, when we assess the notification, we haven't made any determination that we need to be involved, but we have to assess the notification. So be safe, be professional. It might not prevent a notification being made, but the evidence that you can provide in our assessment of the notification can make a big difference between a quick process or a longer investigation. We are more than ever interested in understanding a practitioner's reflections of their circumstance, including the potential vulnerability of their patient groups and of a notifier's experience. And be reflective. It's okay to make concessions about the experience of a patient. It's also okay to admit to mistakes or errors. What we will most want to hear from practitioners are the things that the experience of the patient has taught them, or how this has prompted changes to the way the practitioner practices. And next slide. There's a wealth of information available on our website that I can drop a link into or perhaps disseminate after the webinar. But these are just some of the assessment tools that we use and the principles that we publish so that people can be more confident in what we do as being transparent and accessible. And the next slide. Great. So applying all of these controls helps us identify matters which raise significant concerns. We are interested on practices that align our investigation process to risk assessment and a control approach, allowing us to focus on practitioners and how they respond to reduce future risk and ensure ongoing safe and professional practice. And with that, that's the last slide. And I'll thank you very much for bearing with me while I rabbited through that.
Fantastic. Thank you so much, Anthony. Now, I've got control of the questions. We have some questions in the Q&A box, so I'll just go through some of those, and I'll just, one of them I think is a great one actually, Anthony, could be directed to you. It actually says counsellors and ART clinics comprise of psychologists, social workers and individuals with a general counselling qualification, yet only psychologists are registered with AHPRA. So what avenue of complaint is available for non-AHPRA clinic staff?
Yeah, so where there are practitioners that aren't part of the national scheme or there aren't registered practitioners, we would usually direct that through to the health complaints entities in the state or territory, or the Office of the Health Ombudsman in Queensland. There are other entities that are able to take some conciliatory or some action, but one of the tenets of the scheme is that if you are not a registered practitioner and the profession is not registered, it is a little bit tricky for us to do anything at all. But great question.
Excellent, thank you. Rosalind, would you like to then comment on that?
Sorry, just having some tech problems. No, I think Anthony is better placed to answer that question.
Great, no problems. So the next question, which actually could be put to both of you, is that this particular person working in ART has a concern about the management of patients managed by a competing practitioner. And they're very concerned. They're seeing lots of repeated cycles, and they're very concerned about these consumers. And is it appropriate, or is it a conflict of interest to report them if you're a competitor? Should they report it? Is it constitute grounds to make a mandatory report to AHPRA, or should they report that to the Health Complaints Commissioner?
I struggle to answer that without knowing more of the particulars. I think, as I understand it, there are staff at a provider clinic commenting on somebody else's practices. Is that right?
Yes.
How would they know? Is it from secondhand information? You know, yeah.
Often what can happen, Rosalind, is you can move clinics. So clients can move clinics. Yeah. So you hear the stories because you'll say, "Can I take a history?" So sometimes you have first-hand communication that this is my history and this is what's happened to me.
Yeah, so it's a third person report, which is we take at the HCC. I'd have to know more about the particulars before I can answer that. Anthony?
Yeah, I think from our perspective, we know that there's a lot of sense sometimes that practitioners use the notification process to get back at other practitioners, and there's a competitive element. But what we're really looking at is what is the risk to the public, and we, over the fullness of time, sort of have come to understand that there can be different ways of treating the same patient, and it's perfectly valid. What we'd be looking at is whether or not it was putting the patient at harm. That's our primary test. It does happen that sometimes practitioners feel that there might be an element of vexatious motivation, but we don't know that when we receive the notification. We have to investigate and understand the full context of practice to understand if whether or not there is a risk there.
Okay, great. Thank you so much. A question for you, Rosalind. How did you actually receive different kinds of information at the public forums versus the surveys?
Yeah, it was really interesting. The public forums would tend to be less about the details of the treatment and more about the emotional impact. So we had a lot of tears and a lot of people talking to us and each other, sharing their experiences. And I think with the provider forum, it was really interesting to see the frustrations of providers in dealing with, you know, high maintenance patients, people who demand treatments that they don't recommend, whereas their submissions tended to be very polished and very interesting and lots of statistics. But I think the emotional toll on providers is where we saw it at the forum. And I think that really informed our report as well, to see that, you know, providers are just as frustrated with aspects of the system and the legislation, and that you know, there is an appetite for reform there as well.
Right, thank you so much. Now, question: all people are interested in numbers, so in terms of numbers of reports to each of you as an entity. So both to Rosalind, how many complaints are typically made to the Health Complaints Commissioner specifically about ART? And for Anthony, could you follow up then with how many reports do you get a year, and are they increasing?
Sure. So roughly over the past few years, we've done, you know, quick audits and made sure that we weren't including complaints that weren't relevant. So on average, I'd say we get about 50 a year. Last year we got fewer because there was less treatment because of COVID, but roughly it's between 40 to 60 per year generally.
And we get 10,000 complaints a year. And that has increased steadily as the scheme has matured. And we think a lot of that is just greater public awareness of what we do, as opposed to any significant risks with practitioners themselves. It's just proportional. But what we also see is in that 10,000, 70% of the notifications that we receive result in no further action, which doesn't mean we haven't done anything. It just means we didn't need to do anything from a regulatory perspective. And that can be quite a challenge from the patient and the practitioner's perspective when they hear that 70% result in no further action, because the practitioners sometimes feel that that means that there was nothing there and it was a waste of time, whereas the patient might feel that we haven't listened to their concerns and we've sided with the practitioner. So there's a lot of really delicate messaging that we have to do around understanding what it is that we can do and what we can't do. And we see
sorry,
that.
Nancy, just to clarify, I meant just ART complaints, not all complaints. So 40 to 60 ART. We get thousands as well.
Sorry. I heard that. I did specifically ask about ART complaints, so I did hear that bit. Sorry. All right. No, great. Look, I know there's a couple more questions, but I really think we better allow people to get back to any other commitments they have. So I am going to have to wind it up, but I do want to, before we close, I absolutely want to thank sincerely our speakers again for their time and expertise. We are going to make the recording of the webinar available on our website. We also want to run another information session for clinics about VARTA counselling and donor linking services. So it's already locked in for Wednesday, 16th of February. So please save that date and we will be sending out invitations shortly. Now, when this closes down today, there's going to be a short feedback survey following the webinar, and that's going to pop up in your browser or your device. We do want feedback because, as I said, feedback is always an opportunity to hear from you and to hear what is important to you and what worked well for you today, and what further education you'd like from us in terms of other topics in the future. So we do want to provide more education going forward in this format. Wow, I've got some breaking news. Our annual report is going to be up on our website on Monday morning at 9 a.m. This is going to coincide with the launch of the Your Fertility Week. And our theme this year is Sometimes It's Hard to Have a Baby. As you would all be aware, Your Fertility is a collaboration between many fabulous organisations who are all committed to really promoting and understanding and educating around fertility and infertility. So it's a wonderful campaign this year. I'm very excited about it. And Sometimes It's Hard to Have a Baby would resonate with many people, particularly in terms of the work we all do. So that brings the webinar to a close. Thank you for joining us and enjoy the rest of your day.